Well, Morning at NTV is dedicated to championing women. The future is in her, therefore you've got to invest in her, and that's what we're committing to do here all throughout this month. I am Priscilla Regina Naroga, and welcome to our Kickstarter, which is still in the same regard, focusing on maternal and perinatal death surveillance as well as response. Now, to just give you a backbone of it, in 2013, the World Health Organization launched the Maternal Death Surveillance and Response Guidance to strengthen notification, review, as well as respond to maternal deaths. This guide emphasizes the need for each maternal death to be notifiable, an event, and reviewed to be able to understand the underlying causes to create a response mechanism to avert future deaths. A continuous cycle of surveillance and response. Now, from the survey, 81% of the countries did report a national policy or guideline requiring notification of all maternal deaths within 24 hours. Is that a reality for us in Uganda? Well, we're going to be finding out what it is for us, our case. And then 83% from the same study of the countries reported a national policy and guideline requiring a review of all maternal deaths. And then 67% of the countries reported a national policy or guideline for review of neonatal deaths. However, less than half of the countries, and I'm talking about 44%, reported a national policy or guideline requiring review of stillbirths. Now, this year, Uganda is going to be hosting the annual event on the issue, and we traverse these ideas with experts and doctors in this field. From the World Health Organization, and that is the best in Geneva, we do have Dr. Allisyn Moran, who's joining us, and of course here to speak on behalf of the government of Uganda and what the government is doing to champion this issue. We do have Dr. Richard Mugahi, the Commissioner, Reproductive and Infant Health under the Ministry of Health. Now, salutations shall be to my guests, but of course, ladies first. It's Ladies Month. So, Dr. Allisyn.
Yes, please. Thank you so much. It's a great opportunity to be able to be here today and share some of this exciting work that's going on. As you mentioned, Priscilla, we know that maternal, newborn, and stillbirths are still a huge burden globally. And from our latest global estimates, we know that there are approximately 800 deaths a day of women due to complications of pregnancy and childbirth, which is still unacceptably high. Although we have seen great progress and reduction over the past 20 years, there's still any woman who dies giving life.
Definitely.
It's too much.
Yeah, we have lost sisters, mothers, and friends in that regard. Dr. Mugahi, you're most welcome, and good morning to you.
Thank you, Priscilla, and our viewers. It's a pleasure to be here this morning, and of course, being a Ladies' Month, and it's something that's very close to the ladies and our mothers and our women and sisters. So our talk today is really about how important it is for Uganda to host this global convention of global experts. It's actually already going on. It started on Monday, and it's ending on Friday. And these experts are convening from more than 18 countries, are convening here in Uganda, in Kampala.
Now, before we get into the reason as to why the experts are all in one country, in one room, let's first have an analysis, especially from the ministry's side, of where we stand as far as maternal health is concerned in Uganda.
Uganda, in terms of maternal and child health, we are making progress. Of course, with challenges, but there is progress. We've been able to reduce the number of women who die while giving birth, and this has been a progressive journey from around 525 to 189. Still 189 is a high number, the way we count that.
And this is in what time frame?
Per 100,000 in the last 20 years.
Okay.
From 525 to 189 per 100,000 live births, and that has been over the last 20 years. We are seeing the number of women who are delivering under skilled birth attendants also going high, which is very positive, though we still have a couple of them who still deliver in villages, they under traditional birth attendants, which is a big issue now because we've improved access. So that number that's delivering under skilled birth attendants is 91. Our target is to have all women deliver under skilled birth attendants. because you never know when a complication appears, and that's where we tend to lose people, mothers specifically. But also the newborn is also an area of interest. When we are talking about the mother, we also talk about the newborn. As she mentioned, the number of newborns who are dying is very high, as some of the national reports have showed that the biggest number of deaths in Uganda in terms of a demographic group, age group, it's the newborns who are dying most.
And this is 0 to how many months?
Newborn is 0 to 28 days. That's
28 days.
The highest number,
Wow.
10%
Wow.
of Ugandans who are dying. So
Okay.
it's very painful.
Within that 0 to 28 days,
Yeah.
what have been registered as the common causes of those deaths?
Oh, good one. That's a nice one. We have all this information. For us as programmers, we are able to analyze what is killing these newborns, where are they dying from, what can we do. So that is partly what MPDSR is about. It's auditing, it's finding out, it's using evidence to guide decision making. So primarily what is killing these newborns, the biggest group that's dying, we call them early neonatal death, because they die before 7 days, and the biggest cause of death is birth asphyxia. Birth asphyxia is failure to breathe or getting difficult in breathing immediately the baby is born. The causes can actually be that the mother has been carrying this baby for long, prolonged labor, and any other causes that are around childbirth, or it delayed to make a decision. Maybe baby could have been delivered by cesarean section, but actually goes for the natural method. So the baby comes out tired, and there are no facilities to resuscitate. But a number of babies are dying.
Yeah.
I think a couple of days we said Kampala loses like 70 per week.
It does. I mean, last year we were doing a lot of stories between
Kawempe, so we are still having that crusade. It's massive.
Yeah.
And remember, we are trying to replace an aging population, people who are probably going out of this world, and we are losing this human capital that's probably coming through.
Okay.
And we think the more women keep losing their babies, the more they continue giving babies. So somehow the family planning doesn't work because the mothers are losing their babies.
Oh.
So that's the situation now.
And Dr. Allisyn, one wonders if family planning is one of those reasons for some of these deaths. But anyway, as you come in, we want to have a better understanding of this maternal death surveillance and response. Why was it initiated by World Health Organization in the first place? What were the catastrophes that were happening that caused the attention and caught the attention of such a global organization?
Yeah, no, thank you. Thank you for the question. And I think, you know, during the Millennium Development Goal era, so between 2000 and 2015, there was a specific global target on maternal mortality reduction. And there was quite a bit of progress during that time period, but it wasn't enough to reach the goals that we needed to. We didn't attain what we had all committed to achieve. And so there have been, over the years, many countries have done maternal health audits to really, as Dr. Mugahi was saying, to really understand what are the causes of those deaths, and then what are the actions we can take to really improve progress and avoid similar deaths in the future. And so there were a lot of global guidance around confidential inquiries for maternal deaths, different publications that came out from the World Health Organization. But what we did back in 2013 was say, okay, we know that these audits are important, but we need to incorporate these elements of response, as my colleague was also saying. So not only reviewing the deaths to understand why they occurred, but how to respond at various levels of the health system to address those deaths. And so this whole concept of maternal death review and response came into light, and we published global guidance in 2013. And then since then it's evolved over time, because as we said, also the newborn and the stillbirth are a huge issue, and so really need to do something similar on the perinatal side, which is stillbirths as well as early neonatal deaths. And so we published global guidance on that in 2016. And so since then, I think for the last 10 years or so, we've been working with our country and regional offices and partners and ministries of health to really think about how we can implement these approaches to make a difference and drive, as we're now in the Sustainable Development Goal era, so that we can achieve those targets.
Okay, and so over the course of the last 10 years, for example, what have been those guidelines or apertures that you've encouraged your partners and different ministries of health to pick up on it to help with the surveillance?
Yeah, it's a good question. It's really challenging because now we have the majority globally of births happening in health facilities. So about 85% of births globally happen in health facilities. But that's really been a progression over time. The majority of deaths were really at home for a long time. And so as we've been trying to implement the MPDSR, Maternal, Perinatal Death Surveillance and Response Guidelines, a lot of it is focused on reviewing the deaths in facilities so that we can better understand that, as well as ensuring linkages with communities so that we can identify and notify and review the deaths that are happening in communities. So we've been really focusing on the identification and notification and review of those deaths. And I think that's really improved over time. As you noted at the beginning, many countries now have policies in place to do this. The data are getting better in terms of the capture, the completeness of the deaths that are being captured and reviewed. And now our real focus is on the response, the R piece. So what really can we do, and how do we link more explicitly with quality improvement efforts and others to really make a difference at the systems level, at the community, the facility, the subnational, the district, the province, as well as the national level, to drive change in the facilities to address the really difficult root causes of some of these deaths. It's not always so easy, because a lot of the issues relate to not enough health providers, or ensuring that they have the adequate skills and commodities to be able to do their jobs, which are not easy challenges to solve and take really different approaches depending on different contexts.
Okay, from the health sector, Dr. Mugahi, what have been the continuous challenges, especially on the side of the health service providers?
Yeah, a couple of them, challenges. First of all, we wanted to raise awareness that the public must understand that there is a mechanism when someone loses their dear ones in healthcare circumstances, especially women who are pregnant and their newborns. There is a system, a very systematic way of identifying what caused this death. This is important for clinical practice because we learn from this and we make improvement plans. That is very important, and we want to strengthen this. The report or the interrogation of this death is not meant for someone to go to court. We will never give you this report, and that must be clear. But we sympathize with the loss, the people who have lost, that this death has occurred, but we also put in place mechanisms to improve the system to make sure that another similar situation does not occur. Okay. So that is the continuous process of improvement. So some of the challenges we've had to explain this a lot to the public. They want to go the litigation measures, but we are also working to improve the system. Then the other one, as Allisyn mentioned, our setup of a healthcare system, either it's overloaded and we find there is not adequate care, a deviation from the standards, and this is what we pick as managers, as supervisors of healthcare. If the service providers are deviating from the standards, for example, if a mother is supposed to be monitored every 15 minutes, but there's only probably one midwife who is also in labor suite and delivering. So that deviation, and within 15 minutes something can happen. That is what the standard says. So we find those challenges between the available resources, matching the available resources and what the standards talk about. Okay. We want implementation according to the standards, but some of the inputs to the standards to ensure that we provide the standards are limited. Okay. So that ends up bringing a huge gap to address the real issues. Then, of course, the last one, which we think is a low-hanging fruit, and we constantly, is inadequate knowledge. If we find that, truthfully, the healthcare worker didn't know what to do with this mother, the case was complicated, a little bit above their skill, then we get them an attachment to a center that has that skill set. They are able to give them or update their skill set. We've been doing that quite often, even if it's surgery or something else. So we continuously pick these clinicians, these nurses, take them to higher centers and have their skill sets updated. Okay.
Well, that sounds more reactive than proactive. So I guess later on we'd want to see how proactive government is, because we're not going to wait for these deaths to happen. We can prevent or preventative methodologies. But also something else I'd like you to have speak into is the cost of healthcare. You know, some of these cases maybe can be handled by some of these facilities, but at a cost. And they'll tell the mother that you first have to put this amount of money on the table, then we can attend to you. And in the process, a life is lost.
Oh yeah, just like I mentioned, healthcare is expensive, not only in Uganda, but globally.
Yeah.
Okay.
Yeah, very much so.
Healthcare is expensive.
Healthcare is
not
expensive,
cheap.
especially
and when you
quality
add quality
healthcare.
healthcare,
Yes.
it's very expensive. So for a contemporary Ugandan or an ordinary person, it's definitely expensive.
Okay.
So for the case of Uganda, government has come in to subsidize in the form of offering free healthcare. I was giving a report about Uganda. Of the 1.6 million deliveries that we conduct in this country, 82% happen in public facilities.
Yeah.
82%. We are still battling. Healthcare is supposed to be free, but we also battle with some inputs which are not available sometimes. When they are available, you don't buy. When they are not available, they request you to buy. So with the numbers that we are talking about, the inputs are stretched in a way. These numbers are massive, we all agree. So the inputs are stretched. And when a patient or a relative is told, go and buy, we've lost a couple of them, by the way, for a fact. So go and buy, it's a delay. We call it a third delay. This is a delay when the mother is already in the facility.
Yeah.
And that is our delay.
And they're being told to buy a drug that is 1
we call
million
them
Ugandan
institutional
shillings.
delays.
Yeah.
That's a third delay.
Yeah.
So this is something that we can work on. If we had all the inputs available, then that means we would reduce the incision decision time, when to act. With the time the decision is made to act and when you act. So that is something that this MPDSR actually addresses directly.
Okay.
And we proactively measure some facilities, how they are doing in terms of decision to incision time. Ideally, it should be less than 30 minutes, and action should have been taken.
Wow. It's a tough call. Dr. Allisyn, in that regard, you did talk about the health systems and how, interventions should be cutting across the different system levels. However, of course, I know that there's barriers and local inspired solutions that have been adopted here and there. Could you speak into some of those in order to prevent these deaths?
Yes, no, for sure. It's a really good question. And I think we have a lot of examples from different places and different contexts about, as you were saying, locally driven, innovative solutions to some of these issues. For example, the leading cause of maternal death globally is hemorrhage. The majority of those are the postpartum hemorrhage, which is bleeding that happens after the woman gives birth. And it can happen quite suddenly without any prediction, and it's very life-threatening and serious, especially if the woman is anemic or has some other underlying conditions. And so recently there was a large research study that was done to look, that was called Emotive, that looked at a bundle of services to be able to really quickly, actively manage a postpartum hemorrhage when it occurs. One of the hardest issues for health providers is to understand if the blood that's being lost is enough to categorize it as a postpartum hemorrhage. So a calibrated drape was developed. So women, when they deliver, lay on top of this drape, and then you can see if you get to 500 nmLs, which is a clinical definition of enough blood loss to categorize it as a postpartum hemorrhage, then action, as you're saying, needs to happen immediately, right? So it helps to reduce that incision to decision time, because you, as a health provider, are able to more quickly diagnose a problem. When you're trying to manage 10 women who are giving birth and in labor at the same time, it's very challenging. So I think that the innovation of that drape is really exciting, and now there's a lot of interest in different countries, including in India and lower, LMIC country manufacturers, to develop a drape that will be cheaper to procure and purchase, as well as biodegradable, so that it's not another piece of plastic being thrown into the environment. Yeah. But I feel like those types of innovations could really save lives. They're now recommended in our WHO guidelines, and I do think there are innovative solutions for local manufacturing and use of this, so that we can really address the leading cause of maternal death in a proactive way.
Okay. Let's talk about systematic analysis of the overall mortality trends, as well as the events that are contributing factors to these individual deaths over the course of time.
So the individual deaths. So sorry, can you repeat the question, Priscilla?
The trends that have been observed through the surveillance in regards to what it started with this, and then it has progressed to hemorrhage, as you've mentioned, or what other things have secondarily come up.
Yeah, no, it's a really good question. And I can't speak specifically to Uganda because I know you have really good data on this, but globally we have seen that the major causes of death haven't really changed so much over time for maternal death or newborn death. as well as stillbirths. So we're still seeing the major causes of death are two direct obstetric causes like hemorrhage, hypertensive disorders of pregnancy, and sepsis. We are seeing over time, especially in countries that are transitioning to middle income status, that there's a greater proportion of deaths that are due to more indirect causes such as cardiovascular disease or other sort of non-communicable diseases as populations age and change over time, the maternal age increases, etc., as well as underlying factors that may contribute to maternal death. So we are seeing some changes, but in the data that we have globally now, it's still the same three main causes of death. And the same on the newborn side, it's still birth asphyxia, prematurity, as well as infections. And so I think it's really important that we address those really very clearly, and those come out clearly in the maternal perinatal death surveillance and review.
Dr. Mugahi, how do you draw the linkage between those particular nature of deaths and the community? What's the linkage there?
Yeah, as she mentions, the major causes of death, hemorrhage is bleeding in the lay language, hypertensive disorders, high blood pressure during pregnancy is a killer, it's number 2. Sepsis is you're getting an infection when you're that period, when you're pregnant and 6 weeks after giving pregnancy. So that the major killers. Now the link between the community and these killers is in the simplest way, there is a delay number 1. There's a delay we call a delay at community level. There are 3 major delays, or 4, that kill mothers. Delay number 1 is delaying at home. Our women are not empowered enough, and that's why I really want to link this with women.
Yes. Pain. Like,
yes.
Yeah, exactly.
My husband is not around. My husband is not around. I don't have transport. How will I go? Let me wait for him.
So new mothers, they have no idea what their body is responding to.
Even the old ones, surprisingly, the old ones have trouble.
Okay.
This is usual. This is normal. I can withstand this.
Each baby is different. Is the excuse.
So that's delay number 1. It's actually the leading cause. Delay number 1. We call it delay to make a decision. We need that decision to be made as quickly as possible. I need to seek help. And now, remember, some of our facilities are deep in villages, so access is still a challenge, but government has tried to improve. I was reading them a report. In the last 3 years, we've upgraded more than 400 health centers to be able to deliver mothers in the entire country. Now, that is delay number 1. Then delay number 2, now I have made a decision, but I'm not able to reach where I'm going. The road is bumpy. The bridge on the other river broke. I was washed away.
It's raining.
It's raining now. The transport. We are trying intervention ways. We've introduced ambulances, but they are not yet enough. And some villages are really deep. Even ambulance cannot reach there. So that causes a delay number 2. You see, decision was made, but now there's a delay here. Now you reach a facility, there's delay number 3, which I talked about. Sometimes a health worker, these are within our means, health work is not available, it doesn't sleep at the facility. Sometimes the facility is not ready for this mother. They came without informing the facility is not ready. And that's what we are working on. This MPDSR is picking the low-hanging fruits. How do we make the facilities ready? How do we make the health workers ready for emergencies? Because they'll happen anyway. The woman will not tell you, I'm going to deliver at 7 in the morning, so be there at 7, any time of the night. So facility readiness or complication readiness is one of the things that we're emphasizing. But we're also telling pregnant women that we need you to have a birth plan. Sit with your husband and have a proper birth plan. Where are you going to deliver from? Do you have a contact of someone you will call? Because anything can happen. There is quick labor that we call precipitate labor. It begins anything. And you may not even need, some of you use so many scans, and the scan is telling you next week, but labor begins today. So that level of preparedness at family level, at individual level, at facility level is what is going to save mothers. So that's my link with community and what we are doing. Thank you.
All right, so that's very interesting. Having a birth plan, it's the first time I'm hearing of it.
Yes, and we have a template. We have a clear template.
Let's talk about that in depth. What is a birth plan? What should it look like for any given mother?
For Allisyn? The mother is here, but I can go.
No, I mean, it's excellent, and we have been recommending these, birth plans. We call it birth preparedness and complication readiness, right?
Yes.
Yes, as you were saying as well, Dr. Richard. So it's really an idea so that you sit down with your family and also with your healthcare provider, the midwife who you're seeing for antenatal care, or the doctor, so really decide together on, what are you going to do? What do you want to happen during that birth? If you go into labor and your husband isn't home and you need to get to the facility, what's your backup plan? If you need to ensure that you have gloves, make sure you have them already. If you need to make sure that you have some sort of medication for a pre-existing condition, make sure you have that with you. Make sure you have, things to bring the baby home in, as well as, other things that you might need to prepare beforehand in case for a normal birth or in case a complication occurs. What facility will you go to? Why? Is that facility available 24 hours a day? If not, maybe you try to ensure that you go somewhere else if any sort of problems occur. And then everyone's supposed to sign it at the bottom so that you have sort of a pact or an agreement between yourself, your family, and your healthcare worker about what you really want out of that birth. So it's easy to say what to do in hypothetical terms, but in reality, that's where really the rubber hits the road, as we say, and see if then you can actually implement the plan as you had hoped to. It's not always possible because things happen all the time, completely unpredictable, but at least you're trying to have a plan in place to avoid any sort of contingencies that may occur.
And just to add a little, Priscilla, for me, I think this is magical. Most of the maternal death that we audit, because we have a robust audit system in Uganda, the problem is lack of preparedness. The individual is not prepared, the facility is not prepared, everything, the emergency occurs, and there is rush. Every time we have rush, every time panic sets in, mistakes are made. Mistakes are made. There's rush, there's panic. Absolutely no reason. We're expecting an emergency. The cannula that we have is not the right cannula. We have oxygen, but the oxygen delivery tubes are not available. So that level of preparedness is what we are fixing with this. So there is a clear template of a birth preparedness plan. And if there's any pregnant woman out there listening to this message, when you reach the facility where you're doing your antenatal classes, please request your clinician to have a birth preparedness plan with you. We have a clear template. We even complication readiness. And this has helped us a lot. We used to find women with previous scars, they are laboring at lower level facilities because they are closer to them. But that's not where they're supposed to be. A woman with a previous scar or who has had a cesarean section should deliver at a facility that has a theater. But with this, all this is discussed in the birth preparedness plan. So we tell you early that you can't deliver from here.
All right. So I believe these are some of the conversations that we're having in the technical working group meeting.
Definitely.
So tell us more about this technical working group.
Thank you so much for the question. And so we've been talking about this process called maternal perinatal death surveillance and response, which you described very nicely at the beginning, Priscilla. And so this has been a WHO recommendation for about 10 years now, and so we have a technical working group that's led by WHO but works very closely with our UN partners as well as with our colleagues at country level to really think about what is the global guidance that's needed as well as how to really support different countries in implementing this approach. So we try to meet together, we meet together quarterly, virtually, and we try to get together face-to-face once a year. And the purpose of these meetings is to really look at the critical activities in our work plan and review them, and then also think about, what's really happening, what are the areas that require some more attention and more thinking, and how can we address them together. I think, having the meeting in Uganda this year has been a great privilege, and we so thank the Ministry of Health for hosting us here. It's because Uganda has made incredible progress in implementing at national level their MPDSR system, and Dr. Mugahi can talk more about that. But I just wanted to note one other thing, because at this working group, we're really been spending a lot of time looking at the legal frameworks that underline the MPDSR system, because a lot of times these reviews are done and the health worker gets blamed. And so we really are trying to work with developing legal frameworks to protect the providers so they feel comfortable saying when deaths occur, talking about what really happened, because we have to have that information to be able to do the response and have a plan in place to address those issues.
All right.
And Uganda has a really great system. We've had MPs involved in the meeting and others, so it would be great to hear more about that, I think.
Well, thank you so much, Dr. Allisyn. Dr. Mugahi, thank you so much, Commissioner.
Thank you.
And I trust the Ministry of Health is doing everything in its efforts, powers and endeavors to, especially speaking to the frameworks, the legalities and the guidelines, the principles that, or the policies, sorry, that have to be adopted in order to make this no more discussion for us here in Uganda. We're going to be taking a short breather. When we return, we want to look at Lake Victoria, the tragedy that happened yesterday, where about 10 people have lost their lives so far, and others are still missing from the drowning, the boat that capsized. Ivan Kewadunyo will be giving us that update.